Welcome everyone tonight. Thank you for coming. My name is David Young. I'm the cardiologist at Barton. I know many of you, and thank you for your continued support. I was asked to give a heart lecture because this is Heart Month, and one of the things I wanted to speak to you guys about is the effects of high altitude on your heart. I want to preference this by saying that I trained at sea level. High altitude heart disease was never taught to me, and it's something that as we've worked through this clinical year, I've seen more and more of the effects of high altitude on the heart and wanted to convey some of this information to you. So I want to keep this open. If anywhere along the line anyone has a question, wants to ask me about something, please feel free to interrupt me. And then of course at the end we'll have plenty of time to answer questions as well. So tonight I'd like to talk to you guys a little bit about what the physiologic response to altitude is, and tailor that into what we call periodic breathing of altitude, how altitude affects your respiration. I'd like to talk a little bit about what this periodic breathing can do, the effects on the cardiovascular system and leading to sleep apnea. Talk to you a little bit about the treatment for altitude-induced periodic breathing and some of the things that you guys can do to stay healthy here at high altitude. So I thought I'd torture you right off the bat with an equation. I can't help it. It's part of it. It's physiology. But the environment here at Lake Tahoe and in high altitude in general is defined as what we call hypobaric hypoxemia. So hypobaric refers to low pressure, and the hypoxia refers to low oxygen levels. Now, when you talk about breathing in air, what drives the air into your lungs down into the capillaries, into the tissue, is the partial pressure of oxygen. And that is what's defined in that equation. So the PiO2 is your partial pressure of oxygen. And that's a function of the amount of oxygen, the fraction of oxygen that you breathe in, which stays constant somewhere around 21%. And you multiply that by the barometric pressure minus another constant, which is the water vapor pressure. Now you can see here in this equation that three of the variables are constant. So the FiO2 is a constant, and the 47 millimeters of mercury is a constant. So therefore, the partial pressure of oxygen is really dependent on the barometric pressure or your atmospheric pressure. Now the atmospheric pressure decreases exponentially with altitude. So I've put this graph here on the left represents the barometric pressure, and on the right, which would be your x-axis, that is the altitude in terms of meters. So I put a couple bars on there. You can see lake level, 62.25, approximate elevation. The barometric pressure is probably about 20 less than it is at sea level. And then as you climb up to the top of Kingsbury Grade, it continues to decrease further. And as you head out to some altitude like 10,000 meters, which would be, I guess, Mount Everest at that altitude, the barometric pressure is non-existent. They're already short of breath. So you can see then, as you climb up in altitude, the problem is your barometric pressure drops, and the percent of oxygen in the air therefore drops as well. So what we're dealing with up here at Lake Tahoe is lower oxygen than you're dealing with at sea level because of the lower barometric pressure. And you can see that the oxygen saturation will also drop with an increase in altitude. So many times we'll see patients in the office and they have an oxygen saturation of 95%, which if you're at sea level you might consider to be low, but that may be perfectly normal up here at this altitude. So how does your body respond to this? Well, it's this really complex biofeedback mechanism. So you have these receptors which are located in the vasculature in your body, particularly in your carotid arteries, which feed up to your brain, and in your aorta, which is the main blood vessel in your body. And they have sensors in them. And the role of these sensors is to detect changes in the oxygen level and to detect changes in the carbon dioxide levels. So when you come up here and your oxygen levels drop, these chemoreceptors sense this and trigger your body to what's called increase your minute ventilation, meaning you increase how deep you're breathing and how fast you are breathing to get more air into your lungs. Now, this whole theory is called loop gain, and part of the abnormality they think that happens to people at altitude is how responsive you are can be genetically determined. So for instance, if someone is really sensitive to PaO, to your oxygen levels, you may detect this lower oxygen level and have a heightened response which leads you to hyperventilate to increase your oxygen levels. Now, as a consequence of that, you blow off all your CO2 levels. That's how that respiratory equilibrium works. On the same sense, someone may have a heightened sensitivity to the CO2 levels. And if the CO2 levels start to rise, then that can cause you to hypoventilate. So there's thought that some people genetically are just chemosensitive to these changes in either oxygen or CO2 levels. In addition, in some patients who have a low flow state, so say you have congestive heart failure, and your heart doesn't squeeze as well to circulate the blood around in your bloodstream, it may take longer for these chemoreceptors to detect these changes and to shut off that feedback mechanism. So a lot of physiology, but the point is that your body senses these changes in oxygen and CO2 levels, and that's how it determines how you breathe. And in some people, you may have some genetic susceptibility to either hyperventilate or hypoventilate based on these levels. So, this process of what I'm describing to you is the initial part of acclimation to high altitude. So when someone comes from sea level up to, say for instance, from the Bay Area up to Lake Tahoe, the first thing they notice that they do is they're breathing harder. And that's in response to that hypoxia to increase their ventilation rate. So you're breathing deeper and faster. You're increasing the delivery of oxygen because you're taking in more breath and you're breathing more. And you're compensating for the low oxygen and low partial pressure from the low barometric pressure. As a consequence, though, you blow off all the carbon dioxide in the gas exchange. And carbon dioxide is what's used to help maintain the pH of your body. Your body is maintained at a stable pH, somewhere around 7.4. And if you blow off all the CO2, which is what makes the acid in the body, then your body becomes alkalotic. The pH starts to increase. So they call that a respiratory alkalosis, meaning you breathe off all the CO2 and your body's now alkalotic. Now, this first stage, this hepatoventilatory response of this acclimation to high altitude, is inhibited by alcohol and any type of sedatives. So it always makes me laugh, because I think back to when I was 21 coming up here, you go out and have a bunch of beers and then snowboard the whole next day, which is probably the worst possible thing you could do. But that initial acclimation is strongly inhibited by alcohol. So if you do have someone, family, friends that come up here from a sea level location, they do recommend that you avoid alcohol for at least 48 hours until the body can activate. Now, I will say a word about sedatives that I find interesting. So mostly we're referring to hypnotics, medications you use for people to sleep. But paradoxically, they find that Ambien actually may improve the periodic breathing that people suffer at high altitude. But I'm very cautious about that in prescribing sleep medication to individuals who I suspect may have sleep disorder breathing at this altitude. Okay, so we talked about how the lungs respond to this. Now, how does your body respond to this alkalosis? Because you can't stay alkalotic. And what happens is the kidney starts to sense this. The kidney is the other organ that's very important. And what it does is it excretes something called bicarbonate, which is sort of the buffer or the alkalotic substance in your body. So your kidney starts to excrete this bicarbonate, and as a consequence, you diurese, you pee a lot. So when someone comes up here to the high altitude, they start to urinate frequently. That's that alkalotic diuresis. And that does two things for you. One is it concentrates your blood, so you have more blood cells per unit volume, which allows you to carry more oxygen to the tissue. But the downside is you get dehydrated. So that's why people get a headache. They're dehydrated. And if you decrease your blood volume, then the output of your heart can be affected because there's less volume to pump forward. Your heart's output is dependent on your heart rate and the volume of blood that it pumps forward. So if you decrease the volume, you have to increase the heart rate to make sure you contain the same cardiac output. So what about some circulatory changes? Well, your body doesn't like to be hypoxic. That's not normal. So it sort of goes into a stress response. And the stress response is to secrete a hormone called epinephrine, which is adrenaline in your body. And what that does is it causes your heart rate to go up, and it constricts the vasculature in your body, which will make your blood pressure go up. Your lungs also don't like the hypoxia, the low oxygen. So what happens to your pulmonary vasculature is it constricts as well. And the reason it constricts is it squeezes down on the blood vessels and forces the blood to go up into the upper portions of the lungs, which are better aerated. They have more oxygen there. So it helps improve the oxygenation by shunting blood flow up to the top of the lungs. Now, this can cause problems. So patients that ascend to very high altitudes and they get more and more vasoconstriction, particularly if they ascend too fast, can cause a condition called high altitude pulmonary edema, which you may see in various movies where they're coughing up the bright red blood and has to be treated with a steroid, usually dexamethasone, to suppress. I don't expect anyone coming up to Lake Tahoe will have that happen. But if you're a mountaineer, I'm sure it's something that you have, you've heard about. So your blood changes, and this is probably the best physiologic effect that has been studied at high altitude, and why people like to come train at high altitude. Because you make more red blood cells. Your oxygen is low. The body knows your oxygen is low, and it wants to increase the number of red blood cells that you have to carry more oxygen to the tissues. But this is not an immediate response. Remember, you do get a little bit of concentration from the diuresis, but it takes at least 10 to 14 days to start rebuilding new red blood cells. And that equilibrium that you reach takes almost a couple months to achieve. The blood cells are smart too. They know I only have to carry more oxygen, but I have to deliver more oxygen to the tissue. And there's a series of biochemical adaptations your body does to help unload that oxygen into the tissue and into the cells where it's needed. Now, if these physiologic acclimation processes go wrong, then you develop something called acute mountain sickness. And there's a spectrum of this. There's this acute mountain sickness, and then there's a high altitude cerebral edema, and then eventually progression to high altitude pulmonary edema. But again, these are really dependent on how high you go, and how fast you go, and how much activity you do when you go up to that high altitude. The symptoms, for those of you that have guests that come up, you all are probably acclimated to it at this time. Headache, malaise, poor appetite, you sleep really poorly, sort of described as a very bad hangover for reference. So again, I would say for people coming up, avoid alcohol for the first 48 hours and don't pursue in any type of heavy physical activity if you're not used to high altitude until your body has a chance to acclimate. So those of you that have lived here for a long time, your body has already adapted to this. And the things you've done is your hypoxic, that ventilatory response gets reset. The body gets used to the lower oxygen levels. So it resets those chemoreceptors. And what I'm wondering is, maybe people that have abnormal chemoreceptors, it's harder for them to reset and they carry on some of the abnormalities of breathing continuously. You also have more red blood cells we talked about. The red blood cells are designed better to hold on to the oxygen from the lungs and deliver it to the tissue. You have more capillaries, so there's more ways to diffuse the oxygen out of the bloodstream into the tissue. And there's other, advanced physiology where you can decrease the gradients and allow the oxygen to easily perfuse into the tissues. But for the most part, you get better at breathing, you get better red blood cells to compensate for it, and more red blood cells. Now again, the symptoms of acute mountain sickness and these changes that get people in trouble really aren't described until you get to about 8,000 feet. So we're at an altitude that should be less than what is being described to cause these acute mountain sickness. Now some of you, I understand, live close to 8,000 feet. I certainly felt this when I lived in San Diego. My father lives in incline at 7,500 feet, and I had all these symptoms every time. I'd wonder why I could run 10 miles in San Diego and then run up his stairs in his house and feel like I was going to drop. And that's why. So again, I don't think anyone needs to come out of here panicked that you're living at high altitude and it's hurting you, because most of these changes really start to kick in once you get above 8,000 feet and start to increase exponentially as you increase in altitude and at the rate at which you increase altitude. Usually should not go more beyond 8,000 feet than about 1,500 to 2,000 feet a day. So what happens to your breathing? Well, what's described at high altitude is called this periodic breathing. And what that is it's sort of this waxing and waning of respiration. So you have periods of hyperventilation in response to the hypoxia, which is then balanced by periods of not breathing. And what we call medically patients that don't breathe is apnea. So you may have heard of sleep apnea. That refers to lack of breathing during sleep. So again, you get hypoxic, your oxygen levels are low, you hyperventilate in response to the hypoxia, which leads to low CO2, this hypocapnia, which then your body senses, so you stop breathing to allow the CO2 levels to rise back up in your body. But the consequence is, if you stop breathing, then you get hypoxic again, and that whole cycle perpetuates. But I want to distinguish this between obstructive sleep apnea. So there are two forms of apnea that people can suffer from. Obstructive sleep apnea is typically found in patients who are overweight, have a large neck circumference, may have small jaws, oversized tonsils, anything that can obstruct the airway moving down into the lungs. So you can sort of see in this cross-section of the jaw, here's the normal airway passage, but in someone that is obstructive, in this case a big tongue, it can fall back, prolapse into the airway, and obstruct the airflow down into the lungs. So in these patients with obstructive apnea, you're trying to breathe, but you can't get the air in. That's different to the periodic breathing of high altitude, where you're not breathing and you're not moving air. Different mechanism. So altitude's not the only thing that causes this central sleep apnea or this periodic breathing. Sometimes it's called idiopathic, meaning we have no idea what causes it, is just there. Otherwise, in patients who are really obese, you can have a hypoventilatory syndrome that triggers this. And this is very, very common in patients who have congestive heart failure. So in patients who have low output of their heart, their oxygen levels are low because of the low output. They hyperventilate because of the low oxygen, develop the same low CO2 levels, and have that same periodic breathing. That also happens in patients who have an acute stroke. So frequently when we work in the coronary care unit, patients with bad heart failure will demonstrate this breathing, and it's called Shane-Stokes respirations in that regard. Now there's also a way to hypoventilate, and that's usually in patients who take long-term narcotics. So someone who's on methadone therapy, and I would probably put OxyContin in this therapy as well, that suppresses the drive that suppresses your drive to breathe, which can cause you to stop breathing, develop hypoxia as well. So here's periodic breathing. Again, on the top bar here, this is normal respiration. Even flow, even pattern, and consistent. This is the periodic breathing of high altitude. Here is your hyperventilation in response to the hypoxia, the development of the hypocapnia, of the low CO2, the apnea, which then triggers the hypoxia again, and off you are in the same cycle. And this is how we diagnose it in our office. So I started seeing all these patients, these classic signs. They don't look like they're overweight, but they have all the symptoms of sleep apnea. They're having high blood pressure and atrial fibrillation, everything that we correlate with sleep apnea. So what we started to do is measure their oxygen levels at night. And we put this little thing that's called a pulse ox on their finger, and I'll show you some pictures of that later. And then we followed it. And here's an abnormality. So on this axis is your oxygen saturation, starting at 100, going all the way down to 60. On the bottom graph is the heart rate. Your oxygen saturation should be above 90%. There's no reason for it not to be. But you can see here, as the patient starts to fall asleep, there's these dips in the oxygen saturation, which I believe correspond to these periods of hypoventilation in this central apnea. These were not in overweight people who we would diagnose with obstructive sleep apnea based on their body habits and risk factors. Here's another example. Oop, let me go back. Not sure how to do that. So, there we go. Again, patient falls asleep. Markedly abnormal oxygen saturations. Everything in the red is abnormal. Blue represents normal saturation. Not people who I would characterize as obstructive sleep apnea. But clearly something is happening to their respiration at night to make their oxygen levels drop. So what symptoms are we looking for? I would put these symptoms in both central sleep apnea and obstructive sleep apnea, with the only difference that I didn't put up there is loud snoring. So if you have a spouse that snores to bring down the house, I would highly encourage them to come see us to get this checked. But people feel sleepy because your sleep's interrupted. You get hypoxic. Your body senses the hypoxia. It startles you. You get aroused at night, so you have this fragmented sleep, which leads to daytime sleepiness. And patients can actually have higher rates of accidents during the next day because their concentration is poor from the lack of sleep. Sometimes people get chest pain at night, angina, from a lack of blood supply to your heart because the oxygen levels are dropping so low. Again, we talked about urination. Frequent urination at night can be a sign. Sometimes people wake up and they feel like they're gasping or choking for air. And that's a lot of time when it gets described to me in the office. It says, hey, listen, my husband or wife, they snore and then all of a sudden they're gasping for air. And that's a sign to me that there may be a problem with the breathing. Mood problems. People get depressed. They don't feel as energetic. And again, anytime your spouse stops breathing at night, I would highly encourage them to come be seen. So what happens to your blood pressure? So let's switch out. So we kind of talked about, we've done the physiology, how your body adapts, how it affects your breathing. Well, how does this all tie into your heart? Well, one of the most common things we deal with is hypertension, high blood pressure. It's more common amongst people with sleep disordered breathing. I use the term sleep disordered breathing to now encompass not only the central sleep apnea, but the obstructive sleep apnea as well. How severe your sleep apnea is usually correlates with how bad your blood pressure is. So if you have severe sleep apnea, you're almost 3 times more likely to have hypertension than someone who doesn't. One of the real common times I see sleep apnea is someone who has what we call resistant hypertension. So they'll be on at least 3 blood pressure medicines and come in with a blood pressure of 160 or 170. And you're scratching your head going, God, how much more medication do I have to give you to bring down this blood pressure? And you'll find that if you test these people, a high percentage of them, 71%, have sleep apnea that hasn't been treated. Now the downside is, and the discouraging part of that, is that when you treat the sleep apnea, it usually only leads to a modest decrease in the blood pressure. So most of the time I still have to medicate you for the blood pressure, but less medication than I would otherwise. And in many cases, can take out that resistant factor. Now the pulmonary hypertension, again, we talked about this vasoconstriction. But usually this is only mild, and this is a good thing for you because, again, you're moving the blood up to the top portions of the lungs so you can help oxygenate it. But in some patients who have bad lungs, this can be terrible. So if you have things like emphysema, a form of chronic obstructive pulmonary disease, you don't have that pulmonary reserve that you used to. And increasing the pressures in your lungs can lead to bad things, particularly failure of the right side of your heart. So if I see a patient who I think has sleep apnea, and they have low oxygen levels during the day as well as night, then that's a patient who's at high risk to me and can develop right-sided congestive heart failure. So coronary artery disease, the other very prominent part of cardiology. If you have severe sleep apnea and you leave it untreated, chances are you're going to have more complications from the coronary artery disease than someone who doesn't have sleep apnea. Whether you're talking about heart attacks, getting admitted for chest pain. You know, a heart attack is sort of a syndrome that progresses. So there's what we call unstable angina, which means you're having chest pain but no evidence of heart injury, all the way up to what we call an ST elevation infarction, where there's complete occlusion of a blood vessel and an acute cessation of blood flow to the heart. If you treat the severe sleep apnea, you have less of a chance of having a cardiovascular complication from your underlying coronary disease. So if you have coronary disease and you have severe sleep apnea that you're not treating because you're intolerant of CPAP or can't handle the mask, I strongly encourage you to come talk to us so we can help you with that, because there is a clear reduction in cardiovascular events with treating the apnea. Now, interestingly, if you only have mild sleep apnea, maybe it's good for your body to be a little hypoxic, because if you have an occluded artery, your body can sense that and use those levels of hypoxia to do something called angiogenesis, which you generate new blood vessels. So you allow your body to bypass itself, to grow arteries from one side of the heart over to the other to feed the area with a blocked artery. Interesting. But severe sleep apnea doesn't work that way. Now, what about your heart rhythm? Well, your heart rhythm is strongly affected by sleep apnea and periodic breathing of high altitude. Most of the time, we see bradycardia, which stands for slow heart rhythms. But you can have asystole, which is a complete lack of a heart rhythm, no electrical conduction, and it can last for as long as 10 seconds. We have one patient who has terrible sleep apnea. He won't wear his mask. He says, there's no way I'm wearing this. I can't take it. And he has atrial fibrillation as a consequence. And I said, well, hey, let's check your heart rhythm overnight to make sure everything's okay. 8 seconds with no heart conduction on this rhythm. So I finally said, this is awful. I can't sit here and look at this. You're killing me with this. And I said, I'm thinking about giving you a pacemaker because of this. He says, I don't want a pacemaker. I'm not getting a pacemaker. I said, okay. I said, how about oxygen? Would you at least try oxygen so I can do something to help prevent this? So we put him on 3 liters of oxygen. That 8 seconds turned to a longest pause of 3 seconds and just corrected the hypoxia. But bradycardia, very common in patients with sleep apnea, and it can persist into the following day. So you can have slow heart rates the following day, which further contributes to your fatigue and lethargy. You treat the sleep apnea, the bradycardia goes away. Okay. And it's not like patients with sleep apnea, for the most part, have diseased conduction system, where if you've had high blood pressure or coronary artery disease, the electrical conduction to the heart gets damaged and frays over time. They're normal. It's just an imbalance of the nervous tone, they think. You have 2 nervous systems, a sympathetic and a parasympathetic nervous system. It's an imbalance of your parasympathetic nervous system which leads to the bradycardia. So here is an example. This is a patient with sleep apnea, and I'll try and walk you through this. So up top is the oxygen saturation. What I want you to focus on here first is the breathing movements. So again, here's the hyperventilation, followed by the apnea. Heart rate drops off. Oxygen saturation drops off. That is the physiology of how everything's tied together. Begins with the apnea, which leads to the hypoxia, which leads to the bradycardia. This is asystole. So this is an example of an EKG tracing, an electrical tracing of your heart in a patient with sleep apnea. Fast heart rhythm, probably in response to the hypoxia, followed by no electrical conduction, which is known as asystole to us. Now, let's switch gears from a slow heart rhythm to a fast heart rhythm. And what I'm going to describe to you guys is called atrial fibrillation, which is the most common heart rhythm disorder we see in cardiology. Chances of you developing atrial fibrillation increases with age, so by the time you're over 75, you got about a 10% chance of developing this arrhythmia. Most of the time, we see it in response to things like high blood pressure, coronary artery disease, leaky heart valves, weakened heart conditions. But sleep apnea is very correlated with atrial fibrillation. So in a normal heart conduction, you can see that an electrical impulse will be generated from up here in what's called your sinoatrial node. That's what makes a sinus rhythm. Travels down to another node called your AV node, and then passes down through special electrical tracts in the ventricles, your right ventricle and your left ventricle. And this passage of electrical activity is what causes your heart to contract. And it's designed specifically to rhythmically contract. So the electrical activity spreads through the atrium, then pauses in the AV node to allow the atrium to contract and to prime your ventricles so you can maximize the heart output. Now in atrial fibrillation, it's completely chaotic. So you lose this synchronized electrical activity, and what you've developed in the top chamber is this chaotic electrical depolarization. So you can go from a top rate of 60 to 100 beats per minute to the top chambers contracting anywhere from 400 to 600 beats a minute. They're fibrillating, they're wiggling. And what happens is you lose about 15% of your heart's output in this arrhythmia because you lose that synchronization and the optimization of your heart function. So the EKG, instead of showing this nice electrical activity, will show us this irregular tachycardic fast heart rate. So 32 to 82% of patients with atrial fibrillation have sleep apnea. And to me, when I see someone with sleep apnea, or atrial fibrillation, I always inquire about sleep apnea. Are you sleepy during the daytime? If you sit down to watch a movie in the middle of the afternoon, do you fall asleep right away? Very high correlation, particularly with what we've seen up here in Lake Tahoe. And more importantly, so if someone comes to see me with atrial fibrillation, they say, I feel terrible. Because some people feel awful in this rhythm. They feel fatigued, lethargic. Some people have no idea. But if I'm going to shock you out of atrial fibrillation, put you back into your normal heart rhythm, it's very important to me whether you have sleep apnea. Because if I don't correct your sleep apnea, you can see there's an 82% chance that your atrial fibrillation is going to come back, which is unacceptable. As opposed to 42% if your apnea is treated, or 53% if you have no history. So if you have atrial fibrillation, and we're contemplating putting you back in your normal heart rhythm, it's very important that we establish whether sleep apnea is there and make sure we're treating it. What about congestive heart failure? Well, we sort of touched on this a little earlier. The heart output is weak. It's not pumping blood forward. It's not delivering the oxygen. You're hypoventilating. You're hyperventilating from the hypoxia. You're developing hypocapnia and hypoventilating, getting apneic. That's that Shane-Stokes respiration we talked about. How bad you have it really depends on how bad your heart failure is. Terrible end-stage heart failure, very common to observe this in the hospital. Now what's emerging is, can sleep apnea cause heart failure? Because you know heart failure has two syndromes. You can have heart failure even though your heart is functioning normally. It's pumping fine, but it doesn't relax as well as it used to. And that's an evolving clinical syndrome of heart failure that we think may be caused by sleep apnea. So how do we diagnose sleep apnea? So I was going to say you have these symptoms, you go in to see your doctor, you say, listen, I'm tired during the day, my wife says I snore at night, I want to be checked for sleep apnea. Well, traditionally you undergo something what's called a sleep study, which is a polysomnogram. They offer it at Barton. It's an overnight study where you go in, it's hard, you got to sleep, and you have a number of electrodes hooked up to your body. You got ones on your brain, which measure your brainwave activity. You got tubes in your nose that measure your oxygen saturation. You have something on your chest right here, which determines if your chest wall is expanding. So that's how we determine whether it's obstructive or central. Because if you're not having any movement here and you're not breathing, then that's a central sleep apnea. Then you have your oxygen saturation monitor. And then you get the full report, which is similar to the one I showed you guys with the low oxygen saturation, which led to the bradycardia. Now here comes the worst part. This is where I really get yelled at. The treatment is usually what's called positive airway pressure. So you have a mask, usually begins with something called CPAP, which is continuous positive airway pressure. And it is a very, very hard therapy to get used to. it takes several months and a lot of time working with the oxygen companies to find the right mask that fits to your face. Because what this machine does is it blows in pressure, because it's been designed for treatment of obstructive sleep apnea, where you have a narrowed airway. So it blows in this air at pressures that you can set from anywhere of 5 centimeters of water to 15 centimeters of water to keep that airway open to deliver the oxygen. But my problem is, I'm not seeing obstructive sleep apnea. These aren't people who are snoring. They're not obstructing their airways. They're just not breathing because of the altitude. So I didn't want to do the sleep study. So I said, let's come up with another way. So this is what we're doing in our cardiology department. If someone comes in to see me that I think is high risk for sleep apnea, we measure your oxygen levels. We have you wear something called a pulse oximeter overnight, that there are oxygen companies that deliver to your house. We get that back. If it's abnormal, meaning like the ones that I saw earlier with the desaturations, I say, let's put you on some oxygen at night. 2 liters, like you see in the hospital, the little prongs. We repeat it again, look at it. If it's still abnormal, sometimes we'll increase it up to 4 liters a minute, and then repeat it. But if it's abnormal at that point, then it's hard for me to believe that we're just dealing with hypoxia, which is triggering this. Because there's no way at 4 liters you should be getting hypoxic. And at that point, I become concerned about you having some type of obstructive, coexisting obstructive event, and will send you for the formal sleep study. Now, not all sleep apnea is clear-cut. Either you have central or obstructive. There's usually some combination of the two, and some patients can have a condition called complex sleep apnea, which requires both positive airway ventilation as well as bleed-in oxygen therapy. So here's an example of the pulse oximeter. This is what it does. It tapes on your finger. I did one for fun, although it was a low altitude. And what it measures is your oxygen saturation, and it measures your heart rate, and it stores this information over the course of when you're sleeping, and when the oxygen companies come pick it up, they bring me that report. And this is an example of the oxygen therapy that we're using. This is a nasal cannula. It has 2 prongs, sits in your nose, hooks over your ear, hooks up to an oxygen concentrator, which delivers a steady flow of oxygen. And here's some examples of what we've seen. So here's another gentleman, abnormal oxygen saturation during night. You can see they gave me this report here. So he only spent 52 minutes of the time he was sleeping with a normal oxygen saturation. Almost 7.5 hours of the night he's sitting there hypoxic. It's hard for me to sit on that. How do you leave that untreated? So I said, let's put you on some oxygen. Brought him back. Perfect. Perfect oxygenation all night on 2 liters. So who's at risk? I mean, the last thing I want is everyone running out of here saying, God, I got to move out of Lake Tahoe, I'm hypoxic, my breathing's steady. I think that's the wrong message to take. But I think there are some people who, if you're experiencing these symptoms that I described, that it would behoove you to come get it investigated. And maybe if it's only mild, we say, hey, maybe we don't treat that. But the patients that we identify that are severe, I think there is serious cardiovascular risk by leaving that untreated. So as you get older, it gets more common. If you're a man, you have it more prevalent than if you're a woman. If you're overweight, particularly if you have daytime low oxygen levels, that is a very negative prognostic sign and should be treated. If you're someone that has chronic pain issues and you take heavy narcotics, particularly long-acting narcotics like methadone or OxyContin, I would encourage you to have it checked. If you're a heavy drinker, particularly at this high altitude, I would have it checked. And if you have cardiovascular disease, so you have diagnosed congestive heart failure, you have this resistant hypertension, you're getting chest pain at night that's awakening you from sleep, or if you're having heart rhythm abnormalities that occur when you're sleeping, I strongly encourage you to have it checked out. Now, how do you stay altitude? First of all, she's going to get mad at me, I know, because she said every doctor just says exercise. Well, it's exercise. Maintaining an ideal body weight at this altitude, I think, is essential. So I would say, number one, like every other generic physician, please exercise and lose weight if you're overweight. Now, smoking has twofold. Number one, when you smoke, it inflames the airways, which can further lead to obstruction. Also, when you smoke, remember, every time you smoke, you're killing your lung tissue. It's causing irreversible damage to your lung tissue, which makes it harder for you to compensate for the hypoxic environment up here. I would encourage you to avoid excessive alcohol, particularly if you're someone that may have mild sleep apnea, as well as excessive caffeine use prior to sleep, and stay hydrated. Okay, it's very important to stay hydrated up at this altitude. The other thing I would say, staying healthy, is CalSTAR. I can't tell you how many patients have come in to our office who we see after they're flown to Renown or Carson Tile for an acute MI and are staring at a $30,000 bill for their helicopter ride, which their insurance doesn't cover. It's incredibly affordable. I think it ranges anywhere from like $30 to $40 a year. It covers your whole family. It covers the whole household. So if you are someone who's elder, possibly with a cardiac disease, I can't encourage this enough. We have plenty of flyers in our office. All I encourage you to do is just take one, call them, say, here's my insurance information, am I covered or not? And if you're not, I would strongly encourage you to do it, because we can treat about 90% of the cardiovascular disease here at Barton. But some stuff I just can't do. If you're having an acute MI and need an angiogram and a stent put in, I have to airlift you out of this hospital because time is everything. And this certainly makes it a lot more palatable to do. So I think I'm going to stop. I know that's a lot of information, but that is what we and our staff have been seeing here since we've been working dedicated over the last year in terms of high altitude, how I feel it's affecting the heart, and I just wanted to take the time to convey that to you guys. So thank you for being patient and listening. Any questions? Yes, sir.
Related to the symptoms you first spoke about,
yes,
when people initially come to this altitude,
yes,
and the effects on that, how does that relate to people that commute up here from Gardnerville?
Very interesting question. So Gardnerville is a higher altitude, so you're probably, what, 4,500 feet in Gardnerville on the valley floor? So you're only talking about coming up 2,000 feet, which I think is well within the range of what is safe to travel on a day basis, so you should not have effects from that. That should not affect you.
8 hours, 10 hours?
That should not affect you.
How about in the climb over the summit? Was it beneficial to them to stop part of the way up?
Yes. So I've had several people tell me when they come up over the summit, it causes chest pain. They get angina going over the summit from the low oxygen. For most people, 99% of the people, it's no problem. You're not going to have any physiologic consequence of it. But if you do have coronary artery disease, and you have something that you're susceptible to those low oxygen levels, yes, I would ask you, if you're going over a high summit pass, to stop.
I came on behalf of a coworker that also has a heart disease with emphysema.
Yeah. Well, it's a double factor.
Yeah. So that would help to possibly stop.
Yeah, it may help, if they're not feeling well, it may help to stop. Sometimes people even need oxygen. I mean, they may need oxygen therapy coming over a high altitude summit if they're getting that hypoxic that's causing, once they're getting chest pain, then you're not getting blood to your heart. And there's a whole cascade of events that happen in terms of blood supply. And chest pain is one of the last things you feel.
He's talking about me, and I'm very fortunate that I don't have the pain. But I thought that perhaps, while I'm driving, I commute back and forth.
Yes.
And that's what I was asking him, is perhaps if I stopped on the way up and on the way down, would it be more advantageous to the stress on my heart?
It may.
Okay.
It may. Now, most of the time, people recommend that when you stop to acclimate, you do it for a period of 24 hours. Obviously, that doesn't work for you.
No, that doesn't.
But you try. Try it. And again, I don't have all the answers to this. Like I said, this is a new and emerging part of cardiology that we're learning and experiencing. And if you go dig up the cardiovascular literature on treatment of periodic breathing at high altitude, there's about this much in the journals. So I would tell you that, yes, I would try and stop if you're feeling poorly, and particularly if, I don't know about the severity of your emphysema or your heart disease, but if you're feeling poorly, you may benefit from oxygen therapy as you commute.
Oh, I'm on oxygen.
Okay.
Yeah. I just don't have it with me.
Yeah. Yes, sir.
When you were at higher altitude, you develop a higher red corpuscles in the blood.
Yes.
Now, does that help with the temperature? You know, if you get acclimated, you don't notice the cold as much as if you came up directly from, I've heard this, that phenomenon creates this adaptability to the temperature better.
I don't know. I still freeze up here sometimes. Maybe I'm just a weakling. But yes, you do increase more red blood cells in a response to the hypoxia. That's part of your compensatory mechanism. And whether those increased red blood cells lead to less vasoconstriction when it's cold out, you don't feel as cold, I don't know the answer to that. It's a good question, though. I'll get to it. I'll work on that. Yes?
There is a tie between anemia, high diffuse anemia, and poor control of the body function.
True. No, that I would believe, yeah. So maybe if the negative correlation is there between anemia and feeling cold, then maybe the reverse is true between a higher red blood cell mass and not feeling cold. Thanks, Simon. Yes? Yes.
What is the normal method or normal personal anti-altitude?
Well, that depends. So it's different between male and female. Okay, so I don't have an exact number.
You get a normal range every time you get a lab.
Yeah.
It should be higher than normal.
It should be higher. Okay, so you're going to have a slightly higher range than someone who lives at sea level. So whether a normal hemoglobin ranges from 12 to 14 grams per deciliter, maybe 13 to 15. So somewhere up above, the normal for someone at sea level. So you should be on the higher end.
And if you have someone who is in AFib, what would the resting heart rate be or something like that?
Well, that depends. So the problem with atrial fibrillation is that your heart rate can go very, very rapid. So we have to use medications in many instances to slow down the bottom heart response to all that chaotic electrical activity. So I try and keep someone between 60 and 80 at rest, and when they exert themselves, I don't like to see the heart rates go over 130.
With medication, though?
With medication. And usually I put a monitor on their heart to help kind of depict how much medication it takes to get them down into that range. Yes?
We just moved up here not very long ago, so everything, our blood pressure, we have a baseline of what our blood pressure is and everything. As we stay here longer and as we get older, is this something to anticipate as a medical condition, or is it not necessarily, it's not going to happen to everybody who obviously moves up to Lake Tahoe, but we all experience the same lack of oxygen. So, I mean, you were talking about a genetic predisposition to it. Is there any way of testing for
There's
something
no way
like
of
that?
testing for it. So like other medical conditions where I can draw blood from you and send it in for genotype testing, I can't do it for this. And those are postulated hypotheses of why some people are affected more than others. Now, obviously, you're at very, very low risk for the sleep disorder breathing that we're talking about. Now, the blood pressure is very interesting. So I have a number of patients who stay here in the summer, but then take off in the winter. And every time they do that, I got to down-regulate their blood pressure medication when they go to sea level. So I know that people have higher blood pressure up here than you do at sea level in response to the hypoxia.
So if you see your blood pressure changing and going higher,
Yeah.
and all the other, your diet and your exercise and everything has stayed the same, is that something you should think, okay, this is something to look into?
Yes, yes. So, I would never overreact to that. I would give you a 6-month period and say, hey, listen, why don't we track this? I mean, depending on how high it is, if you show up at 180 over 110, I'm less likely to say, let's watch this for 6 months. But a normal blood pressure ranges anywhere from 120 to 140 on the top number. So I may just say, hey, let's keep an eye on it, see how it fluctuates. Maybe you adapt to the high altitude, you reset that ventilatory response, and your blood pressure drops back down. But sometimes that doesn't happen, and people need to be treated up there.
One more question.
Of course.
It seems when you are sort of susceptible by age to AFib, that the first thing you do is put you on blood thinner.
Wow.
Yeah.
Let me explain that. Not because we like to. No one likes to put someone on blood thinner because there are consequences of blood thinners. And the main blood thinner consequence, or the main blood thinner that's used, is warfarin or Coumadin. And the biggest concern about we have is bleeding, particularly as you older, the rate of bleeding in your brain. Atrial fibrillation, when your heart is doing that chaotic rhythm, it no longer contracts. It doesn't push the blood out. It just pulls and then passively drains into the ventricle. And when it pools like that, you can form a clot in your heart. And if you get a clot in your heart, it's usually on the left side. It breaks loose, gets pumped into the circulation, goes up to your brain and causes a stroke. Now, not everyone with AFib is at risk for a stroke. There's very specific defined criteria. So if you're over 75, that's a risk factor. If you have high blood pressure, that's another risk factor. If you have congestive heart failure, that's one. If you're diabetic, that's one. And if you've had a stroke before, then you have double the risk. So if you have a score of 1, or say a score of 0, you don't have any of those, then an aspirin is fine, full-strength aspirin. If you have one of those risk factors, it becomes very debatable whether you use an aspirin or Coumadin. If you have more than one, then definitely being on a blood thinner such as Coumadin. Now you may see on the news there are several new blood thinners which have come into the market, one being Pradaxa and the other one being Zarletto, which are both medications that have been studied and are just as effective, if not better, than warfarin at preventing stroke. But each one of those has their own independent downsides. That's why we do it. Yes?
Yeah, like for 9 months of the year I live in London, Ontario, which is about 1,000 feet above sea level.
Okay.
I've been coming up here to Tow for the last 7 years. And this year, for the first time, for me, I'm having difficulty sleeping. So I'm either drinking alcohol to put me to sleep, or I'll take a sleeping pill. But I'm finding if I'm laying in bed, I'll have difficulty breathing, so I've got some nose drops that clears my nasal passages. And so I can, if I do all of that, not necessarily the alcohol, but I can get a good night's sleep.
Yeah.
So I'm curious, I guess, as to whether that's physiological or psychological.
I would say physiological, hopefully not psychological. The nasal congestion that you define, so it's dry up here, which leads to nasal congestion. And having nasal congestion can trigger obstructive sleep apnea because you just can't breathe through your nose, you're obstructing the airway. So that may be what you're experiencing when you come up here. But you're naturally going to acclimate for the first couple of days you're up here. Now that's an average of first couple of days, so there's got to be some variation in that. Maybe it takes some people a couple weeks. And having trouble sleeping at night is one of the most common symptoms of acclimating to high altitude, which should get better. Now, if it doesn't get better, I would say after 3 weeks to a month, there may be some other things to look at. And maybe you're one of the people that would benefit from just checking your oxygen levels overnight. May help define that issue. Sound like an oxygen representative. Yes?
Well, I was wondering about someone who would have a chronic problem with breathing, like I have asthma.
Okay.
And so, is that a risk factor for in the high
No,
altitude?
I have never heard about any correlation between sleep disordered breathing and asthma.
Because you're already, having a lack of oxygen
Right.
sometimes. But, so,
I don't know of anything that's correlated those two. In all the research I did for this, I did not see any mention of asthma.
because my asthma seems to have gotten better.
The second person that's told me that.
Yeah.
Someone else told me today that they moved up from California and they had asthma and they were on all these bronchodilators, inhalers. And then they came up here and their asthma was totally better. So maybe it's the clean air. Less air, but clean air. Yes, Lynn?
Are there any long-term benefits of living at high altitude besides kind of the sports and dropping down to low altitude and memories?
Don't know. Don't know that. I mean, I would say that having a red blood cell mass, if you have coronary disease, is beneficial. Sometimes I think of patients with coronary artery disease who I'm trying to put through cardiac rehabilitation, that exercising in a mildly hypoxic environment is beneficial. But whether you live longer at high altitude, I don't know. I hope. But I will find that out. I will tell you. Yes?
Is there a website you can go to or a source of information if you have hypertension and you're trying to get it lower without? We're trying to
Sure. So the American Heart Association has a bunch of information.
Okay.
So for hypertension, if you don't want to take meds, which I don't blame you, I don't like giving meds out. The things you can do, big ones, increase your aerobic activity. Okay, American Heart Association recommends about 30 to 40 minutes of aerobic activity a day, most days of the week.
Okay.
2, decrease your sodium intake, somewhere to around 1,500 milligrams a day, which will be hard when you start looking at all the salt that's in food. 3, avoid alcohol. Okay, 1 drink, great. 2 drinks, borderline. More than 2 drinks definitely will cause a rebound hypertension the next day. Okay. Diet, very important. So avoiding inflammatory foods such as saturated fat, trans fats, incorporation of more whole grains, vegetables will help lower your blood pressure as well. Yes?
As far as the salt,
Yeah.
some of the stuff on the internet is talking about sea salts or crystal salts versus the processed salts, and also cooking with it versus putting it on after the food is cooked.
Yeah.
Is that just all nonsense?
I think so. I think so. It's hard. It's hard for me to say. Now, obviously, no one's given you a 10,000 person trial, and some people got table salt, some people got potassium chloride or whatever the salts they're using. I just tell people to stay away from salt. Period. And the people I'm really conscious about that are the ones with heart failure, because when you have heart failure, your body's mechanism is it wants to retain salt to retain fluid, and that's exactly what we're trying to counteract. We're trying to get rid of fluid. So I just stay away from salt altogether. Now, salt has a mild effect on people if you're just talking about hypertension. So restricting your salt may shave 5 to maybe 10 points off your blood pressure. Okay. Well, thank you. I appreciate all your attention.